The gallbladder is a small, pouch-like organ that stores the bile produced by the liver. After a fatty meal, the gallbladder contracts and releases bile to help break down fats in the diet. Bile is mostly made of water, bile salts, bilirubin, and fats, as well as cholesterol. Now, the most common gallbladder diseases have to do with an imbalance in bile fluid composition, which leads to the formation of stones either in the gallbladder or somewhere along the biliary tree. The biliary tree is made up of the left and right hepatic ducts, which come together and form the common hepatic duct, as well as the cystic duct, which unites with the common hepatic duct to form the common bile duct, which is also known as the choledochous duct. Finally, the common bile duct joins with the main pancreatic canal to open in the second part of the duodenum. Now, most gallbladder diseases are related to either the presence of stones in the gallbladder or in the common bile duct, and whether those locations are infected as the result of an obstruction caused by gallstones. A gallstone in the gallbladder is called cholelithiasis, and a gallstone in the common bile duct is called choledocholithiasis, and both are associated with mild inflammation. But if the gallstones block the normal bile flow, this can cause severe inflammation in the biliary tree. When there's a lot of inflammation, the gallbladder and common bile duct tissue becomes extremely susceptible to infection. An infection of an obstructed gallbladder is called cholecystitis, and an infection of an obstructed common bile duct is called cholangitis, or ascending cholangitis. In cholelithiasis, gallstones often develop from an imbalance in bile composition. For example, if there's too much cholesterol gallstones form, and that happens mostly in female individuals during the reproductive period, especially over the age of 40. Other risk factors include being overweight and being Native American. If, however, the bile has too much bilirubin, pigment gallstones form, and this happens with hemolysis, liver cirrhosis, and sickle cell anemia. In some cases, mixed gallstones can appear, and those are made up of variable amounts of both cholesterol and pigments. But in practice, there's no way to know the exact composition of the stone until the gallbladder is surgically removed. Typically, gallstones happily remain in the gallbladder for months or even years without being noticed, because they may not cause any symptoms. In fact, gallstones that are smaller than 5 millimeters can pass through the cystic duct and reach the small intestine and then be eliminated. So in individuals with gallstones, but without symptoms, the gallstones might be discovered incidentally through an ultrasound, and that's called cholelithiasis. Now, if the individual is symptomatic, then we're talking about gallstone disease rather than simply cholelithiasis. These individuals might have biliary colic, which is abdominal pain in the right upper quadrant or epigastric region that can radiate to the shoulder or back, and typically it lasts for less than an hour. Pain happens because the gallbladder contracts against a bunch of stones, and that can temporarily compress the cystic duct. This often worsens after a high-fat meal. Now, although it's called biliary colic, the pain is usually constant, rather than colicky. Associated symptoms include nausea, vomiting, and sweating. The first and most accurate test for diagnosing cholelithiasis is an ultrasound of the right upper quadrant, which shows a distended gallbladder with stones inside. On an ultrasound, the gallstones cast an acoustic shadow below the gallbladder, and they also move freely when the individual turns from one side to the other, and that can help distinguish them from other conditions like carcinoma. In some cases, the gallstones are so small that on the ultrasound they appear as a so-called sludge, which doesn't cast an acoustic shadow. Okay, now for most asymptomatic individuals, the usual plan is watchful waiting. However, treatments necessary for symptomatic individuals or those at high risk for developing symptoms. High-risk individuals include those with hemolytic disorders, like sickle cell disease, morbidly obese individuals who undergo gastric bypass, or individuals who have risk factors for developing gallbladder cancer, like gallstones bigger than 3 centimeters, a calcified gallbladder wall, which is also called a porcelain gallbladder, and gallbladder adenomas. Initially, gallstone disease is treated with spasmolytic, like butyroscopolamine, or in severe cases, with opioids, like buprenorphine, to stop the gallbladder from contracting in order to ease the pain. After that, a cholecystectomy, which is surgical removal of the gallbladder, can be done. Cholecystectomy is curative, meaning that once it's done, no further medication is needed. However, some individuals are not eligible for surgery, like those who can't tolerate anesthesia. In that situation, a medication like ursodeoxycholic acid can be used. Ursodeoxycholic acid decreases cholesterol absorption, and that prevents new gallstones from forming, as well as dissolve the existing ones. Another option for those who don't have a cholecystectomy is a technique called extracorporeal shockwave lithotripsy, or ESWL. ESWL is a machine that uses high-energy sound waves that produce shock waves to break gallstones into smaller fragments, which can then be dissolved in the bile. ESWL is a non-invasive procedure that's usually used to break down kidney stones, but it works in individuals with a normal body mass index who have less than 3 gallstones between 4 and 30 millimeters. There are some contraindications for ESWL, like pregnancy, cholecystitis, choledocholithiasis, pancreatitis, and coagulopathies. In choledocholithiasis, try saying that 3 times fast, a stone gets stuck in the common bile duct. Most frequently, this happens when a stone spontaneously passes through the cystic duct, which is wider in some individuals, and then gets stuck in the common bile duct. However, in rare situations, gallstones can also form directly in the common bile duct. Those are typically made mainly of bilirubin and are called pigment gallstones. The risk factors of choledocholithiasis are similar to the ones for cholelithiasis. In choledocholithiasis, bile accumulates behind the obstruction, which blocks the flow of the entire biliary tree, and in some cases can back up into the liver, resulting in jaundice. Other symptoms include abdominal pain in the upper right quadrant that lasts more than an hour, as well as nausea and vomiting. On clinical examination, Courvoisier's sign may be present, meaning there's a palpable gallbladder. This happens as a result of the obstruction of the common bile duct, which makes the gallbladder dilate. Courvoisier's sign is usually associated with malignant common bile duct obstruction, but it can also appear in choledocholithiasis. Blood tests will show leukocytosis, and because of cholestasis, meaning something, which in this case is a stone, is blocking the flow in the common bile duct to the duodenum, total bilirubin is high, and especially direct or conjugated bilirubin. Also, alkaline phosphatase and gamma-glutamyl transferase levels are high. Some individuals will have an associated reactive pancreatitis, which happens because the stones compress the main pancreatic duct. Pancreatitis can cause pain in the upper abdomen, which radiates into the shoulder and back, as well as abdominal tenderness, and blood tests will show high amylase and lipase levels. Other individuals will have an associated hepatitis because bile accumulates in the intra- and extrahepatic ducts. With hepatitis, alanine aminotransferase, or ALT, and aspartate aminotransferase, or AST, are also elevated. To diagnose choledocholithiasis, a right upper quadrant ultrasound is done, and it typically shows a dilated common bile duct and intrahepatic bile ducts. The gallstones aren't always visible, and they're in the common bile duct, and they might also be in the gallbladder as well. If the ultrasound is inconclusive, a magnetic resonance cholangiopancreatography, or MRCP, can be performed to confirm the diagnosis. MRCP is a non-invasive technique that uses contrast or non-contrast MRI imaging, which is very good at detecting fluids, like bile, to visualize the biliary tract and pancreatic ducts, and this can also detect gallstones in the common bile duct. Treatment of choledocholithiasis starts with intravenous fluids to prevent dehydration and antibiotics while the biliary tree is inflamed and more susceptible to an infection. To remove the gallstones, a procedure called endoscopic retrograde cholangiopancreatography, or ERCP, is used. With ERCP, a long, flexible tube is inserted through the mouth, down the esophagus, through the stomach, and into the duodenum. Once it gets there, a cannula is passed through the ampulla of Vater, and a sphincterotomy, a small cut, is made above it, where Oddi's sphincter is located. Finally, a small balloon is inflated in the sphincter to further dilate the common bile duct. If the ERCP is successful, then gallstones are able to more easily pass into the duodenum. After that, a cholecystectomy can be performed to eliminate the risk of another gallstone getting stuck in the common bile duct. In cholecystitis, bacteria like Escherichia coli, Klebsiella, or Streptococcus species infect an obstructed gallbladder. That's because these bacteria are always lurking in the gastrointestinal tract and creep up the biliary tree and into the gallbladder when there's no bile washing them back out into the intestines. There's acute cholecystitis and chronic cholecystitis, and they are both invariably related to gallstones. But sometimes, acute cholecystitis can appear in individuals without gallstones, and that's called acalculous cholecystitis, and it's caused by bile stasis. With chronic cholecystitis, gallstones block the cystic duct and then get dislodged, and then again can block the cystic duct and get dislodged. This cycle can happen over and over, and each time it causes inflammation that can result in recurrent episodes of right upper quadrant pain. The pain typically isn't intense, and it doesn't last for more than an hour. This is why chronic cholecystitis isn't diagnosed until the gallbladder is surgically removed and chronic cell infiltration is seen on histopathology. However, sometimes, probably because of the intermittent injury to the gallbladder, its walls can get calcified, and this is called a porcelain gallbladder, which increases the risk for developing gallbladder carcinoma. A porcelain gallbladder can be seen on an abdominal radiography as a well-contoured balloon, or on an ultrasound where the gallbladder shows dense shadowing that can be mistaken for gallstones. The treatment recommendation, once porcelain gallbladder is diagnosed, is cholecystectomy, which minimizes the risk for gallbladder carcinoma. With acute cholecystitis, the symptoms are usually severe, and the individual has a fever, loss of appetite, and pain in the right upper quadrant, which can radiate into the shoulder or back, especially after a high-fat meal. Typically, the pain is constant and severe, and it usually starts as a biliary colic, but it can last up to 6 hours, and it's associated with anorexia, nausea, and vomiting, as well as a mild fever and leukocytosis. Most frequently, on clinical examination, there's a Murphy's sign, which is where an examiner firmly places their hand in the right upper abdominal quadrant under the liver border and asks the individual to breathe in. If the pain worsens, it's called a positive Murphy sign, and it's a classic sign of inflammation of the gallbladder, and a classic sign of acute cholecystitis. Sometimes, abdominal tenderness from peritoneal irritation can be present. However, a positive Murphy sign alone cannot diagnose acute cholecystitis, so an ultrasound is usually done next. A right upper quadrant ultrasound may also result in a positive sonographic Murphy sign, which is abdominal tenderness caused by the pressure of the probe on the gallbladder. It'll also show a distended gallbladder, thickening of the gallbladder wall, and fluid around the gallbladder. An HIDA scan, or cholecystography, can also be performed to diagnose diseases of the gallbladder, liver, and bile ducts. That's where a radioactive tracer is injected into a peripheral vein. The tracer makes its way into the bile, and from there, it goes into the gallbladder, and then through the bile ducts and into the small intestine. In acute cholecystitis, the biliary tree will fill without problems, but the gallbladder won't fill up because there's an obstruction in the cystic duct. Treatment of acute cholecystitis starts with analgesics, such as non-steroidal anti-inflammatories like ketorolac, to help with the severe pain. In addition, intravenous fluids to prevent dehydration and antibiotics are used to treat the infection. For mild and moderate cases, cephalosporins such as ceftriaxone or cefuroxime can be used. For elderly, immunocompromised, or critically ill individuals, meropenem or piperacillin tazobactam can be used, or a combination of metronidazole plus ciprofloxacin or levofloxacin. Like cholelithiasis, the gold standard of treatment in acute cholecystitis is cholecystectomy, which must be performed as soon as possible. If the individual is not eligible for surgery, then a cholecystostomy can be done, which is where a percutaneous catheter is placed in the gallbladder to allow it to drain out. In cholangitis, gallstones get stuck in the common bile duct, and that causes fluid to build up behind the obstruction instead of just flowing through. Once again, this invites a bacterial infection, this time in the common bile duct. Just like in choledocholithiasis, there's cholestasis, and as a result, the total bilirubin, alkaline phosphatase, and gamma-glutamyl transferase levels are elevated. Some individuals have a reactive hepatitis with high ALT and AST levels, or biliary pancreatitis with high amylase and lipase levels. However, a key difference is that with cholangitis, there's severe inflammation in the biliary tree because of the bacterial infection, and individuals can have Charcot's triad, which includes right upper quadrant pain, jaundice, and fever. Specifically, unlike choledocholithiasis, individuals can have a really high fever and be very ill-appearing or septic. In fact, individuals can have Reynolds pentad, which is hypotension and altered mental status, along with Charcot's triad of pain, jaundice, and fever. If cholangitis is suspected, the first step is to draw blood cultures to identify the bacterial culprit. Then, an upper right quadrant ultrasound is performed, which shows dilated biliary ducts. Then, the individual undergoes emergent ERCP, which can visualize the inflamed ducts, as well as remove the gallstones. While the individual is getting ready for ERCP, intravenous fluids and broad-spectrum antibiotics are administered to prevent dehydration and manage the bacterial infection. After results from the blood culture come back, the antibiotic regimen is adjusted according to the specific bacteria at fault. Finally, cholecystectomy is also indicated in acute cholangitis after the gallstone has been removed. Alright, as a quick recap, with cholelithiasis, individuals can be asymptomatic or present with biliary colic. On an ultrasound, the gallstones cast an acoustic shadow below the gallbladder. Treatment in this case is usually cholecystectomy, but ESWL is used in some cases, and ursodeoxycholic acid is used for some individuals unfit for surgery. With choledocholithiasis, the individuals present jaundice, pain in the right upper quadrant, nausea, and vomiting. The blood work shows leukocytosis, high bilirubin levels, high alkaline phosphatase and gamma-glutamyl transferase levels, also high ALT and AST, and high amylase and lipase if the liver and pancreas are affected. The ultrasound shows dilated biliary ducts. Treatment is IV fluids, antibiotics, and ERCP. In cholecystitis, the individual presents right upper quadrant pain, fever, a positive Murphy sign, and leukocytosis. The ultrasound shows thickening of the gallbladder wall, fluid around the gallbladder, and also gallstones. If the ultrasound is inconclusive, an HIDA scan is performed. Treatment for cholecystitis is IV fluids, antibiotics, and urgent cholecystectomy or cholecystostomy if the individual cannot undergo surgery. Finally, with cholangitis, individuals present with Charcot's triad, which is jaundice, fever, and pain in the upper right quadrant. Septic individuals more frequently present with Reynolds pentad, which includes hypotension and altered mental status along with pain, jaundice, and fever. Lab work is similar to choledocholithiasis, and the ultrasound reveals dilated biliary ducts. In this case, ERCP is emergent, and while the individual is prepping for the procedure, IV fluids and antibiotics will be administered.